Thank you.
No problem. I feel slightly embarrassed that I don't actually know what gynaecology actually means.
I'll explain.
Thank you.
That's what I'm here for. Every day I see women that are affected by not only conditions that they have, but also by their ability to access treatment that they need or not. So in simple words, gynecology is helping women live in normal lives again. Sometimes it means helping them deal with pain. Sometimes it means helping them have a family. Sometimes it means helping them avoid major surgery or doing major surgery in a way that's acceptable to women. Increasingly, it means helping women get access to effective treatments that exist, but not everyone is able to access the treatment that will help them.
So, gynaecology, is that female biology? Is that what you focus on?
Yes, it's
Okay.
female health. And I've got an interesting story about a client that came to my clinic last week. She comes to the clinic referred by a colleague. She was a university lecturer, educated, and she sits down and the first thing she says to me, I waited for this moment for 6 years. And I thought, that's interesting. So for 6 years, she nearly burst out crying. For 6 years, she's been told to deal with heavy periods, pain, nobody would diagnose her with anything, and she was just told to go away and deal with it. And it wasn't even the symptoms that she came with that really affected me. It's the fact that 6 years, nobody felt that they required to investigate a symptom that was concerning.
I happen to support a charity for menstrual health, and I'm fascinated by some facts that we get told or we get informed about, that a lot of female medicine or surgery is actually tested on men. Is that right?
That is correct. It's much easier. You don't have to deal with hormones. And we all know how difficult that is.
Yeah.
So researchers are not that keen, and pharmaceutical companies are not that keen. So yes, a lot of research, even testing of things like contraceptive pill or HRT, had originally been done on men. They must have paid them a lot of money to agree to take part in such research, but there you go. Going back to the woman, actually, she had heavy periods, she had pain, she's worried. I asked her, what have you been doing for 6 years? She was doing what one would do, going in and out of GP, she gets reassured, she gets palmed off, sent away, nothing wrong with you. Eventually she manages to get an appointment and she says, maybe I'll have a scan because I'm worried that I might have fibroids. So GP takes one look at her and says, well, you can't have fibroids. You don't look like someone who has fibroids. And I'm thinking,
can we look like someone that has fibroids?
Good question. I'm thinking, what does someone with fibroids look like? And what she said to me afterwards was even more shocking than you think, because you might be thinking, if the fibroid is big enough, that's what I'm thinking, maybe you will look pregnant, yeah? No, GP says, well, you can't have fibroids because you're not black. Because obviously, women of black origin are more likely to have fibroids. So if someone is not black, therefore they can't have fibroids. So it gets worse. Then she looks at her and says, let's examine you. Takes a poke of her tummy and says, oh, no, don't feel any fibroids. So no point sending you for a scan. This is 6 years later. Woman is university lecturer. She says, but I might have cancer. I'm really worried. I really want this scan. Well, there's no point scanning you. You're 42. You're telling me you want children. Even if we find fibroids, there's nothing they can do. It's a hysterectomy or nothing. So no sending you for a scan. And anyway, if you want a scan, just go private because it's going to be a long time, so go private. So she goes private. And funnily enough, she's full of fibroids, big ones. She's now 42. 6 years later, she would have been 36. She's desperate to have a family. So she has a consultation with the GP, says, I've got these fibroids, whatnot. Or, but you're not on any contraception. You're not listening to me. I don't mind not having children. Well, but I'm really uncomfortable you're not on contraception because you're going to be coming in 6 months and asking me to terminate the pregnancy. Funnily enough, even her husband didn't believe her until such time that she had a scan. She thought he thought she was a hypochondriac. She keeps going to the doctors. They're not doing anything. They're not even sending her for a scan. Clearly, nothing wrong with her. And then her husband felt really guilty. Because at the same time, when you think about difference between men and women, he developed a problem with his prostate. And he thought, I must have prostatitis. So he phones his GP. He gets an appointment that day.
But why is this? We're not many men.
Yes.
Why is this? Why does a man call up? I know it's unusual for them to call up, and we should support them to do that and to reach out for help.
Very much so.
But when they do, why is that the case?
When they do, it's all systems go. You're right, we're not many men. And we probably conditioned women to think that their suffering is normal, heavy periods are normal, painful periods are normal, it's just being a woman, not being a woman, it's your hormones, it's lack of hormones if you're postmenopausal. The excuse changes, but no action is taken usually. So he phones up, he gets an appointment face-to-face with a GP. Anyone tried to get an appointment with a GP face-to-face recently?
Yeah.
I'm not even asking if you've been successful, as if you can get through a receptionist and then the nurse and then God knows who, and then your time is up. We're only talking about one problem today. So he gets a scan, he gets a blood test, he gets antibiotics. He's treated in 5 days. Think about it. 6 years, 5 days. Same GP practice, same GP, same postcode, same family. Even the man came home and says, I'm confused. Why are we getting such different treatment?
So you lead on this as a passion, not just your profession. You go and do talks everywhere to try and get people to understand this difference in the gender equity. And what you found is to support women in this gender equity, because you can't do it all, is once they do get to you, that robots can help.
Robots can definitely help.
Go on. Are you in a room with like a massive robot? What happens?
Believe it or not, I am in a room with
you really?
a massive robot.
Okay, go on.
Yes, it's not to go into too many technical details. It consists of 3 parts. The parts that over the patient is the largest. And if you think about it, it's automated arms that hold the instruments. It hasn't got its own brain yet. It can't do the surgery on its own yet, so it's in full control of the surgeon, but you get exceptional precision, 3D vision. It makes you feel like you're inside someone. I've seen things in anatomy that I've never seen before. I've been a consultant for nearly 20 years, and you're able to do surgery that's so precise, with minimum damage, with little or no complications, which all translates into exceptional recovery, which is what allowed us to reduce the length of stay to nothing. You can come in, have a hysterectomy and be home in 2 or 3 hours.
Sorry, and what is that traditionally then?
Traditionally, even people that say they do same day, the stay is usually till the next day.
Okay.
On average, it was around the country is 2 days after keyhole hysterectomy. And if you get traditional, big cut on your tummy, that's 3 or 4 days.
Wow. How have you managed to be at the forefront of this? How have you managed to be a surgeon with robotics to help women even keep parts of their anatomy that other surgeons have told them they wouldn't be able to?
That's the key. The approach to women's health, unfortunately, in this country is still stuck, not even in 1960s, it's probably 200 years before that. Half of women in this country receive open procedures, so big cut on your tummy. Women as young as 30 and below, if they have endometriosis or fibroids, are told we need to remove everything. Pelvic clearance, you see. Whether you've had children or not, that's the best treatment. And it's not supported by evidence, and it comes from not having the knowledge or access or expertise. But you've got another problem, because even though we have the technology, we have people that have the expertise, we have a problem with access. So it's not the innovation necessarily that's a problem, it's a lack of access for women that's a problem.
So give me an example then, endometriosis and someone saying, you know, you've got to have everything removed. What could you and the robot do to ensure that they keep as much as possible?
And if you think about it, a lot of women with endometriosis are young women, women of reproductive age. While having children is not everyone's ambition in life, many women will want to have families. So instead of having everything removed, including the ovaries, may I say, at the age of 30 or below, which should be illegal, we are able to be aggressive on the disease and remove disease aggressively and precisely, but we can be very conservative on the organs. So we don't actually need to remove bits of the body, we can just remove the condition. And even with this extensive and traditionally really complex surgery, we can still do the surgery in such a way that women are able to rest in their own bed afterwards, and there is no need for hospital stay.
So how many of these types of operations have you done? What is the data telling us now in relation to, I'm feeling that every woman should have access to a you and a robot?
We need many of me and many robots.
Okay, so
I'm having one in my garden first.
are you? So how are we supporting the next generation to follow in your legacy? And what is the data telling us in being able to support women with a surgeon using a robot to support them?
Very good question. And problem is probably even bigger than we realise. These days, talking about men, if you're a man in this country needing your prostate out for whatever reason, usually it will be for cancer, you've got 99% chance of receiving robotic surgery. No questions asked, standard of care.
Explain that to me. 99% of receiving robotic surgery.
Yeah.
So they do it with a robot to remove the
robot
prostate.
To remove the prostate.
Okay.
If you're a woman needing your uterus out for
Yep.
comparison, uterus being a womb,
Yep.
you've got 1 in 10 chance of having robotic surgery, to have this surgery. So only 10%. And that's an improvement on 5% that was about maybe 5 years ago. Probably all the cases that I've done in the last few years.
And what is the reason for that?
It's not considered standard. It's not considered required. Even in my own hospital where they've got me, I never shut up about it. And I, as you know, speak everywhere where they invite me to speak about robotics, present at conferences, because what we've been able to achieve is nothing short of exceptional. Robots have been around for quite some time, decades in fact, mainly used for men's health in this country for a long time. But when we got access to the robot, we've been able to transform gynaecological care, and hardly anyone stays in hospital after their surgery, even for one night. So if 100 women have the procedure, 95 or 98 of them will go home 3 hours later. When you say same day, it kind of is a bit abstract.
Yeah.
But when you actually measure it,
Yeah.
that it's 3 hours later on average.
Yeah.
Some will go sooner. And in fact, I had a lady that I just managed to catch the back of, because there was her dressed in her own clothes, with a backpack on her back, saying to me, "Cheerio, thanks very much. I'm away, I'm going to pick my kids up from school." She was just on a theatre table at 9 a.m. This was maybe 12:30, 1. And in fact, if anyone had surgery in the audience, you know, you have an operation, the doctor will come and speak to you, and you get looked after by nurses. We've completely changed to nurse-led discharge, because actually I'm still operating, they're already away.
Yeah.
So if everything is straightforward, they're not going to see me on the day of surgery afterwards.
So while planning for this talk, I've listened to some of the conferences you've done, and you talk about Ferrari versus Fiat. Tell me a bit more about that.
It's one of my favourite slides. You're absolutely right. The slide displays a yellow Ferrari and a yellow Fiat. Both are cars, both are going to get you from A to B in a slightly different way. And I use it to illustrate that actually technology is only worth something if it's changing human lives. Otherwise, it's just toys for surgeons to play with, and for me to listen in conferences and see videos, endless videos of amazing surgery with no relation to human outcomes. Oh, I've done this, and how did the patient do? Oh, she did well. But really? Are you telling me this? Have you shown me any numbers? too often in medicine, we're too focused on the treatment itself that we deliver, rather than thinking about outcomes that women feel. When can I go home? When can I lift my children up? When can I pick them up from school? Maybe that day. When can I go back to work, have sex, do whatever, all the activities of normal life. And I think the more we shift the focus to think about human outcomes, we can design the systems that are human by design and enabled by technology. We do need more technology, but we actually need to put women in the centre of everything we do, and any decision that we as doctors, we as patients or supporters of someone who is a patient, and also policymakers, hospital administrators, we need to constantly be thinking, what does this woman need? And design the service that's appropriate to fulfill those needs.
So you are out on platforms that are inviting you, you're applying for to be able to get this message out. What are you finding that women are saying in relation to how they feel after the success rate? Is this available to all women? Are we going to have to be your best allies and supporters to make sure that all women get access to this? Tell me more about the next steps.
You're all going to need to support me, and we need more of me. And I want to encourage all of you to ask questions and don't just accept whatever you're told as gospel, because it most certainly isn't. The biggest scandal isn't even the lack of access, it's lack of knowledge that there are options. That women are not being told there are different ways. You know, someone came with a large fibroid, her doctor said, oh, it's big up and down cut, no other options. She found me somehow, travelled from other side of Scotland, sits in my clinic, said, I think I've got cancer. I was like, I don't think you've got cancer, but you've got massive fibroids, so what do you want to do about them? Oh, I want them out. I was like, okay, we'll do robotic surgery. Can you really? I was like, oh yeah, watch me. So anyway, we've operated on her. She then post factum tells me, in fact, before her surgery, she's like, I know you said I can go home, but I'm nearly 2 hours away, so I think I will feel more comfortable staying. I was like, that's absolutely fine. You stay, me thinking, I'll do the surgery, I'll go home, that's fine, stay, and have your 3-course meal. She came private. Anyway, we've done the surgery successfully, and I get a call a few hours later from the nurses from the hospital. Oi, are you coming to see this woman? Because she's jumping at the bit, she wants to leave the hospital. She's feeling so calm, she's feeling so well, she's dressed in her own clothes. She's like, I think I'll be more comfortable in my own bed, thanks very much. She surprised herself that she had such a major surgery with big pathology that she knew she had. She felt so well, she thought, why am I going to be stuck in this hospital overnight?
If I'm not in Scotland and I can't afford private, how can we start supporting and campaigning for this availability to all women that deserve to have the same access as that husband that called up and got his in 5 days?
All systems go.
What do we do?
We ask questions. Things are slowly getting better. Things that we have been doing are making a difference, because we've now put it on the agenda of everyone, all the ministers of whatever colour they are, irrelevant, because it's our job to inform and educate and support them to deliver the service that we need. You're doing a little bit better in England. You've got a 10-year plan, and in fact, they've come out and said that in 10 years, 90% of all small detail keyhole surgery is going to be robotic. But actually what we need to think about, should we still be having open surgery in 2026 and beyond? And I can only speak for gynaecology, but I think for benign conditions that are not cancer, that should be a thing of the past. So if your doctor is unable to do it, there are other doctors that are able to deliver it. And I've personally supported many teams to start robotics and to teach them to deliver the care for women that they deserve. So with time, I think the culture is shifting and we're going to have more access. But there is still a lot of work to do, because remember, 10% versus 99%.
And as part of that 10% sitting here, as a female, soon to be 45, who's brown, who is gay, When I go to the GP, I already baffle them with the fact that I'm brown, the fact that contraception, and I say I'm gay, and they don't know what to do after that question. And then, are you a
Ask
parent?
them about smears.
I know.
They don't know what
No, they don't know what to
either.
do. Are you a parent? Yes, but not a biological one. How do you help, very specifically here, how do you help our brown and black sisters, as well as our white ones and everything else, but how do you support us to be able to communicate with the GPs in the first instance, where I still believe there are some biases and assumptions there made?
Very much are, as illustrated by my patient only from a few weeks ago. I couldn't believe what I was hearing, so there are definitely biases.
What type of things should we be asking, or what type of things should we be challenging without being seen as aggressive?
We should be respectfully challenging the recommendations that are given, because actually they might be palming you off, but there is no reason to palm you off. Even taking endometriosis as an example, the first steps are, in simple terms, give someone painkillers, offer some hormonal treatments, which all have a value in delivering the care for this condition. However, even in national guidelines, we've now written that if it's not acceptable to the client to be on contraception, not desired or not tolerated, you have to refer. And actually, it's fine to, if you come with symptoms, say heavy periods, it's whatever you say heavy periods are, they are. I still have women come into clinic and saying, I want to show you the picture of a clot on my phone. And I'm like, thanks very much. I don't need to see it. I believe you. But it's interesting that women feel compelled that they have to have a library of clots and all other things. All sorts of pictures are provided. We've kind of made women believe that this is normal, acceptable, and women are believing that this is acceptable. And the system is now really used to ignore, not act, and the system has become comfortable with women waiting. I think we've all become really comfortable with women waiting.
Apart from the women that are waiting.
Apart from the women that we are not comfortable.
No.
Women are waiting 9 years for diagnosis of endometriosis, even more, interestingly enough, in ethnic minority communities, because culturally it's probably not okay to argue with a doctor or come across as aggressive. I'll just take a treatment that's given to me and walk away. So we all have a job to do to make sure that we shine a light and that we don't ignore. Nobody goes to the doctor for no reason.
So in the last minute or two, as a pioneer, a female pioneer, I'd like to say, because I do champion Allies for All, that's working with robotics, what would you leave the audience with as your final statement?
I think one of the most important things is for us to not lose the sight that we become very comfortable with women waiting. And history will judge us for that. So I think the future isn't necessarily in many new innovations. It's currently in improving access for innovations that exist. We don't necessarily need to develop more smart robotic technology. We need to build systems that are human by design and that keep women at the centre of everything we do, of every healthcare decision we do, however small or large, we all have a role to play.
Dr. Inna Sokolova, thank you very much.